Good afternoon. I'm glad to be here today with you and share some information about significant and fascinating topic: diseases of blood vessels, cardiovascular diseases. My name is Skorik Valeria Ruslanovna. I am Associate Professor of the Department of Pathological Anatomy and Forensic Medicine, Dnipropetrovsk Medical Academy. To start with, I'd like to recommend you to subscribe our YouTube channel. This way, you are going to be aware about all new lectures and other useful videos. Next point. The next point is obligatory. Please do not forget to register in our live chat so we can see who joined us and mark your attendance. Also, feel free to write questions. It's really important because discussion is the best way to get into the particular topic. So, let's begin. Today we are talking about the most considerable representative of group of diseases of blood vessels. Today we are going to talk about atherosclerosis. This slide presents annual number of deaths by cause, and as you see, vascular pathology is responsible for more morbidity and mortality than any other category of human disease. As you see, the number of deaths due to these diseases is in 2 times more as even malignant tumor as cancers. So, this slide aims to remind you basic organization of the vasculature. So, today we are talking about mostly arterial part. We need to remember that we have large-sized vessels like aorta, also muscular arteries. In other words, we can name these like medium-sized arteries and arterioles. Atherosclerosis affects mainly large-sized vessels and medium-sized vessels. What is so specific in these vessels? So, aorta has substantial elastic tissue, as you see, and wide layer of muscles. Also, muscular arteries and arterioles has also ring of smooth muscles, but muscular arteries have a more wider layer compared with arterioles. So, before we start exactly with the atherosclerosis, we need to describe some important terms. First of all, this is arteriosclerosis. This is general term for any arterial thickening and loss of elasticity. So it means that in any sized artery, we can find connective tissue. Due to this connective tissue, we have thickening and obviously loss of elasticity. Moreover, arteriosclerosis is divided into several groups or types. First of them, as you see, this is arteriolosclerosis. Arteriolosclerosis affects small arteries and arterioles. So, this is general outcome of hypertension. So, hypertension mainly affects small arteries and arterioles. Next one is the Mönkenberg medial sclerosis, as you see. This is calcification of the wall of muscular arteries, which mainly involves our internal elastic membrane, and patients after 50 mostly suffer from this disease, but there is mostly again absence of clinical manifestation, so there is no clinical symptoms. And the last one is atherosclerosis. So what is exactly directly atherosclerosis? This is a thickening and hardening of large and medium-sized muscular arteries, primarily due to involvement of tunica intima, and is characterized by fibrofatty plaques or atheromas. So, atherosclerosis underlines the pathogenesis of coronary artery, the cerebral arteries, and peripheral vascular disease, and cause more, as we have already told, a morbidity and mortality in the Western world than any other disorder. So, again, this information you can find, often in your CROC 1. So atherosclerosis affects mostly large and medium-sized artery. So you can say that this is aorta and all main arteries in our body. First place is heart, brain, aorta, as we told, small intestine, lower extremities, and kidney. Atherosclerosis of the coronary arteries, heart. This situation is so common, is too often. So World Health Organization decided to name this type of the atherosclerosis as an unique disease. And this unique disease is ischemic heart disease. So, ischemic heart disease is atherosclerosis of the coronary artery, but due to high incidence, atherosclerosis of the coronary arteries was named as unique disease, ischemic heart disease. So we will look at this classification again in more depth, but a bit later. So, etiology of the atherosclerosis. We need to answer the question why this disease could occur. So we need to list causes, but as you see, there is no causes at all. We can say or we can talk about only risk factors. It's very important. What is the main difference between cause and risk factor? Cause means that if patient has this cause, this patient definitely, mostly 100% sure, will have this disease, will get this disease. Risk factors means that this patient, if this patient has risk factors, this patient probably, so probably yes, probably not, will have this disease. So there is absence of risk factor is not obligatory for the disease. So only risk factors. Consider them in more details on the next slide. So also in etiology we need to talk about theories regarding atherogenesis. So let's go. Risk factors. As you see here, we have two main groups: major modifiable risk factors, minor modifiable risk factors, and non-modifiable risk factors. Modifiable risk factors mean that you, like a future physician, can help your patient and probably save the life of your patient. Non-modifiable risk factors means that you can do, unfortunately, nothing. So, constitutional or non-modifiable risk factors. First one is the genetics. As you know, family history is the most important independent, so non-modifiable, risk factor for atherosclerosis. Second place takes age. Age is dominant influence. Also, the development of atherosclerotic plaque is typically a progressive process. It does not usually become clinical manifest until lesion reach a critical threshold in middle age or even later. For example, between ages 40 and 60, the incidence of myocardial infarction increases fivefold. Next point is gender. Other factors being equal. Premenopausal women are relatively protected against atherosclerosis and its consequences compared to age-matched men. So, for example, myocardial infarction and other complications of atherosclerosis are uncommon in premenopausal women unless they are otherwise predisposed by diabetes, hyperlipidemia, and severe hypertension. Next point is the modifiable risk factors. I please you note the font size. Compare with previous slide. I mean, font size of the letters modifiable major risk factors. They are much bigger compared with previous preceded slide. Why I emphasize on it? Because this something you can cope with. These risk factors you can manage. And if you do this, if you fulfill this like a task, important task, you will save your patient's life. So, first of all, is hyperlipidemia. And if we can say more specifically, hypercholesterolemia. So this is a major risk factor for atherosclerosis. Even if your patient does not have any other risk factors, hypercholesterolemia is sufficient to initiate lesion development. So, what do we have when we are talking about hyperlipidemia? So, as you know, we have two types of lipoproteins. So-called bad lipoproteins or bad cholesterol, and good cholesterol or lipoproteins. So bad, this is low density lipoprotein, and good is high density lipoprotein. So main modifiable risk factor of atherosclerosis is increased amount of low density lipoproteins. Move on. Hypertension. Hypertension is another major risk factor for atherosclerosis. Moreover, both systolic and diastolic levels are important in this case. One more interesting point. Your teachers are going to ask you about this thing. Is hypertension a cause of atherosclerosis? Your answer should be no. Hypertension is just a risk factor for atherosclerosis. Moreover, this statement works oppositely. So, atherosclerosis is a risk factor for hypertension. Next one, modifiable, absolutely modifiable risk factors. I did not say easily modifiable, but absolutely modifiable risk factor. So, smoking. Cigarette smoking is a well-established risk factor in men and actually likely accounts for the increasing incidence and severity of the atherosclerosis in women as well. Some studies stated during the years, smoking of 1 pack of cigarettes or more daily, so per day, doubles the death rate from ischemic heart disease. So make it in 2 times more. And very interesting point. If your patient gives up smoking, he or she reduces that risk substantially. Move on. Diabetes. Diabetes mellitus induces hypercholesterolemia, and that's why markedly, as you see, increases the risk of atherosclerosis. And several words about additional risk factors. I'd like to emphasize one of them. This is metabolic syndrome. Slide that you see right now presents us one of the famous Russian painter, Vasnetsov. The date of this paint is first half of 19th century, and name of this paint is Riders of Apocalypse. 4 riders, as you see, and I make a relation between these 4 riders and 4 partners of metabolic syndrome. So, metabolic syndrome consists of central obesity, diabetes, hypertension, and dyslipidemia. Also, some authors could add in this metabolic syndrome hypercoagulability and pro-inflammatory state. These two actually may contribute to the endothelial dysfunction and or to thrombosis. But anyway, metabolic syndrome is that situation that significantly make worse situation with your patient. So again, I repeat, metabolic syndrome generally associates with central obesity, diabetes mellitus, or any other reason of insulin resistance, hypertension, dyslipidemia. Move on. Theories regarding atherosclerosis. So, as you see, the main model views atherosclerosis as a chronic inflammatory and healing response of the arterial wall to endothelial injury. I'd like to show you a scheme. Atherosclerosis progresses in following sequences. So, first of all is endothelial injury. Endothelial injury, when we're talking about atherosclerosis, is the cornerstone of the response to injury hypothesis. So, as you see here, some list of risk factors. Again, I underline these words, risk factors. But the two most important causes of endothelial dysfunction, please do not mislead. Causes of endothelial dysfunction, risk factors for atherosclerosis. So, the two most important causes of endothelial dysfunction are hemodynamic disturbances in plural form and hypercholesterolemia. So actually these two first. So firstly we need to damage the intima. Intima, so this is, yes, one layer of the endothelial cells. Next one, we have accumulation of lipoproteins, platelets, adhesion, monocytes adhesion, and emigration. These cells under the intima, so here. So atherosclerosis is characterized by some accidents under the intima. Next one. This is not like a cornerstone, but also is a really important point. SMAS muscle recruitment. So, macrophage activation of the macrophages leads to release some factors, and these factors stimulate SMAS muscle to activation and migration from the media under the intima, so here. Next one is lipid accumulation within macrophages. According to this picture, you also see that fat, yes, so this is fat, yellow fat. So macrophages, phagocyte fat, and SMAS muscles also phagocyte fat. But fat also accumulates in the or within extracellular matrix. So this is the first stage that we can assess grossly, because we could assess formation of so-called fatty streaks and fatty dots. Let's see in real situation. So we have here, and here dots, short, and some streaks, as you see, they are long, so longer than 1 centimeter. So fatty streaks, as you have already known, are composed of lipid-filled foamy macrophages. Yes, this one, lipid-filled foamy macrophages. And firstly, they form dots, yellow spots, I can say like this, and they eventually coalesce into elongated streaks, so like this, 1 centimeter and longer. This picture, as you see, this one where I have an arrow, my arrow. So black arrow show us exactly these foamy macrophages. So empty or pale pinkish cytoplasm because of the accumulation of fat, and some empty or transparent vacuoles form. So move on. Last one situation. This is smooth muscle cell proliferation and extracellular matrix production, and this last point actually is a key process, formation of fibrofatty atheroma, as you see, fibrofatty atheroma, or just atheromas. Formation of atheromas, I repeat again, is a key process for atherosclerosis. So, as you see here, and here, atheromatous plaques are whitish, yellowish, or white-yellow, and the most important point, they encroach on the lumen of the artery. Next one. Here you see this red-brown color. So this is advanced atherosclerosis. We are going to talk about it a bit later. I'd like to mention that you can assess at once different stages of atherosclerosis. So here you see some streaks, probably even dots or spots, and here you can see advanced stage of atherosclerosis. This is just atheromatous plaque. This is advanced stage of atherosclerosis. So plaques vary in size and can coalesce to form larger masses. Move on. So again, advanced atherosclerosis, as you see, so these are ruptures of atheromatous plaques or ulceration of these plaques without thrombosis. Move on. Final point is the basic structure of atheromatous plaque. So we have fibrous cap. Fibrous cap means that we have connective tissue. So under the one layer of endothelial cells, we have smooth muscles, macrophages, foam cells, lymphocytes, and especially collagen and elastin. So atherosclerosis is a chronic disease. Atherosclerosis, which can lead to severe acute manifestation, clinical manifestation, is chronic disease. Under this fibrous cap, we have necrotic center. Necrotic center consists of cell debris. You remember what is cell debris? Cell debris is rests of dead cells. I think it's clear. So also cholesterol crystals, formed cells with fat, and calcification. I remind you, so we have two types of the calcification. Metastatic calcification, when we have increased amount of calcium in the blood, so hypercalcemia, and this type is not our type. This type, so this calcium, is dystrophic calcification, when we have accumulation of the calcium in the focuses of sclerosis and necrosis. And as you see, all this plaque, I repeat it again, locates exactly between intima and media. So, to sum up, morphologic concepts: macrophages infiltration, intimal thickening, lipid accumulation, formation of streaks and dots, atheroma formation, smooth muscle hyperplasia and migration, also fibrosis, possible calcification, aneurysm formation, and thrombosis. About these two we are going to talk a bit later. So, very good scheme, I like it. Very easy to get into. So firstly, fatty streak. We have only formed cells and intra and extracellular lipid. Next one, we have we have intra and extracellular lipid and formed cells as well. Next, I'm sorry, I don't know what's wrong. So next position, when we have smooth muscles. So they activate and migrate into the focus of the future atheroma. Next one is advanced plaque. So you see here lipid core, big, huge lipid core, thick collagenous cap. It's very important. Obviously, formed cells and smooth muscle cells. And the last one, complicated plaque or advanced plaque. Here you can see the thrombosis. So this picture can help you to compare mild atherosclerosis on the left. So as you see here, some advanced plaques, but generally this aorta looks is not so terrible and advanced. So here I think it's really easy to see all problems with ulceration, with probably dissection of the aorta. and rupture of the fibrous cap of the plaque. So here I prepared for you some pictures when we can assess that substances that we were talking about. So here all this situation, all these masses is atheromatous plaque. This C, this is cholesterol crystals, some cell debris. So this is the center of the atheromatous plaque. This blue color, this is a specific stain for connective tissue. So it proves us that this is organization and this is really connective tissue. Also here you see the same, so some crystals of cholesterol. As you see with arrows, you see arrows, small vessels, so neovascularization of preceded thrombus. So after the rupture of the fibrous cap, so of the atheromatous plaque, we have a thrombus formation. And this thrombus, I remind you, one of the fate of the thrombus is the organization and vascularization. Vascularization happens as the new vessels, small capillaries form. So next point that you need to be aware. What is vulnerable plaque and stable plaque? Stable plaque has a very thick, as you see, very thick fibrous cap. Oppositely, vulnerable plaque has very thin fibrous cap. It means that exactly this vulnerable plaque can easily rupture, can easily ulcerate, and that's why we will have severe clinical manifestation, acute severe clinical manifestation. Stable plaque means that patient has chronic ischemia. So as you see, this fibrous cap closes the lumen of the artery mostly 50%. So the tissue that is supplied by this artery does not get 50% of oxygen. This is a bit roughly and probably is not perfect medical language, but I'd like you to get into the point. So main problem with atherosclerotic plaques is they close the lumen of the artery. That's why the tissue that is supplied by this artery can't get enough amount of oxygen. So this situation is chronic, and this situation leads to the chronic ischemia. Move on. Advanced features. So rupture, ulceration, and erosion. Rupture, when we have a rupture of the fibrous cap, especially for vulnerable plaque. Ulceration, when necrotic debris, exactly enzymes inside these necrotic debris, just eat from inside this fibrous cap, especially in vulnerable plaque. And erosion, mostly the same as ulceration. So, and these three leads to either atheroembolism or thrombosis. Atheroembolism, this one, atheroembolism means that all this fat inside atheromatous plaque just is free and can, as I can say, like, feel free to flow in the artery blood, so can lead to the infarctions of the organs, because this is atheroembolism, so any type of embolism can lead to the blockage, complete blockage of the lumen of the arteries, so it leads to the acute ischemia, and that's why we have infarction of the organ. Hemorrhage is also acute outcomes or complication of the atherosclerosis. Enzymes, the same enzymes of necrotic debris can eat the wall of the vessels inside the wall of the vessel where these plaques are. So wall of the vessel is damaged, we have hemorrhage. And aneurysm, this one, last one. Aneurysm is the chronic situation. What is aneurysm? Aneurysm means that there is no smooth muscles that can get the wall of the vessel in a good fit. So that's why we have changing the shape of the artery. We will see the example of it, and I will explain you more in depth. So here, atherosclerotic plaque rupture. So as you see here, atherosclerotic plaque, very thin fibrous cap, and rupture of it. You see? So hole, mostly I can say this is a hole, and this is a thrombus. You see, thrombus. So this thrombus, as you see, absolutely, completely blocks the lumen of the vessel. So this thrombus leads to the acute ischemia in the tissue that is supplied by this artery, and through several hours infarction will be. Move on. Very good scheme to sum up all this information. So firstly, normal artery, then fatty streak, then plaque, advanced changes of the plaque. Again, advanced changes means rupture, means ulceration, erosion, means thrombosis, atheroembolism, and aneurysm formation. So all these are here. What we can also mention according to this scheme. So aneurysm and rupture is clear. Occlusion by thrombus is clear. Yes, so there's complete occlusion by thrombus. So acute ischemia and infarction in the tissue and organ. I'd like to emphasize this one, critical stenosis. Critical stenosis, as you see, very small very actually tiny lumen exists in this artery, inside this artery. So this artery does not work properly for sure. This artery, this critical stenosis leads to the chronic ischemia. So there is no infarction in the tissue that is supplied by this artery, but there is a lot of connective tissue as a result of chronic ischemia. So the result of critical stenosis clinically will be chronic pain when patient try to use this tissue, for example, like muscles. So try to contract them. And morphologically will be sclerosis, so development or spreading of connective tissue within affected tissue because of the leakage of the oxygen. So, and the clinical manifestation, I promised you that we go back to this question again. So, heart, myocardial infarction, ischemic heart disease. Myocardial infarction is severe acute outcome or complication. So when we have coronary artery with the ruptured plaque, and this ruptured plaque is complicated by thrombus with complete blockage of the coronary artery. Brain, the same. Chronic ischemic brain damage or dementia. So a lot of connective tissue instead of normal neurons. And cerebral infarction or stroke. So the same, when we have acute thrombus or thromboembolism. Aorta, here we have aneurysm formation and thrombosis as well. Small intestine, the same, ischemic bowel damage, chronic, and infarction, acute. Lower extremities, intermittent claudicating, chronic, kidney infarction, and chronic ischemia. So, cerebral atherosclerosis, as you see here on this very good, this I like this one image. So normal blood flow. This is like critical stenosis when we have really decreased number of erythrocytes which can flow through this small tiny lumen. And this is a great picture that can show us example of embolism. So, for example, atherosclerosis of the aorta, we have ruptured plaque, thrombus formation, and this thrombus becomes thromboembolism or atheroembolism if there is no thrombus but embolism with atheromatous masses. And this atheromatous masses or thrombus can block arteries which are lower than position where they appeared. So when we're talking about abdominal part of the aorta is the most common site of atherosclerosis. In this part, in this situation, we can block arteries of intestine and low extremities. But we can't block the cerebral arteries because cerebral arteries is higher in location than abdominal part of the aorta. Infarction of the brain, again, yes, here is it. So this one, some hemorrhages which surround the infarction, atherosclerosis of heart disease, in other words, ischemic heart disease. This is coronarography. So you see absence of white color. This absence of white color means that there is no blood flow at all. Next one, myocardial infarction. Here is it with some rupture here, rupture. Again, myocardial infarction is acute outcome of the atherosclerosis. Aortic atherosclerosis. Here you can see advanced atherosclerosis, and as you see, ischemia, so absence of or lackage of oxygen, is always manifested by pain, severe, sharp pain. Aortic aneurysm, so as you see, aorta changed the shape. Yes, changed the shape. Here 2, 1, and here are 2. So aortic renal atherosclerosis of renal artery. So if we completely block of the artery, so we have completely decreased amount of oxygen in the kidney. That's why kidney with time will not won't work at all because of connective tissue, because of the sclerosis. So we can name it like mostly exactly this kidney, chronic renal insufficiency. If there is no problem with another kidney, so another kidney will work, and there is no clinical chronic renal insufficiency. There is a stent, so surgeons made this artery wide again, and also this is infarction. As you see, white color, this one. So infarction, again, this is acute manifestation of the atherosclerosis. A lot of, yes, this whitish color, a lot of infarctions, and after this one we will have a lot of scars in the kidney. Atherosclerosis of lower extremities. Here you can see gangrene, yes, gangrene, so changes, and obviously problems with walking. So patient usually complain about the pain in the legs when they just walk. So, to sum up, atherosclerosis is a chronic inflammatory response of the arterial wall initiated by injury to the endothelium. And I'd like to finish my lecture with one picture. I'd like to influence on your mentality, and probably you'll think it over. So thank you for your attention. Thank you for you that you join us, listen to this lecture. I hope it was interesting and fascinating probably for you, and what is more important, really can help you to get into this topic and to make your study not only easy but also more effective. So thank you for your attention. Have a nice day. See you next time.